Good morning. My name is Krista Dela Cruz, and I am a volunteer at the Lupus Foundation of Northern California. I am excited to be your moderator this morning's session. We have a packed schedule today, so I will go over the agenda quickly and then we will get started. The first session, we will have a presentation from Dr. Michael Levin, who will discuss what you need to know about lupus and the kidneys. In our second session, we will host a patient panel, including patients from our Sacramento and San Francisco support groups. You will hear from two lupus warriors as they discuss their lupus journeys and then answer questions. Remember, you can ask questions whenever you would like, but we will hold all questions until the end of the session. You can also ask a question anonymously by clicking on the anonymous button. Now, I'd like to introduce Danny Martinez from Armenia to introduce Dr. Michael Levin.
Thank you, Krista. Good afternoon, everyone. My name is Danny Martinez, and I'm the Strategic Alliance Manager with Armenia. And I'd like to thank Lupus Foundation of Northern California for the partnership and to bring about this very important talk about lupus. We will have a Q&A immediately following the presentation. So at this time, I'd like to introduce your speaker for this afternoon, Dr. Michael Levin. Dr. Levin joined Metropolitan Nephrology in 2006. He's a clinical professor of medicine and chair of the Division of Nephrology, and has won numerous teaching awards and serves in the curriculum committee and is the clinical director of the nephrology course. He has held numerous administrative titles, including president of the medical staffs at Roxborough Memorial Hospital and Jeans Hospital. He remains a director in the Temple University Health System, the director of dialysis at Temple Hospital, Jeans Campus Ethics Chair, and the chair of the Pharmacy and Therapeutics Committee at Roxborough Memorial Hospital. Dr. Levin's clinical interests range from hypertension to chronic disease and dialysis. He serves as medical director of the Fresenius Northwest Dialysis on City Avenue, specializing in their center dialysis and home dialysis programs, home hemodialysis, and peritoneal dialysis. He has specific interest in glomerular disease and has had a chance to interact on several panels regarding treatment strategies of challenging glomerular lesions. And with that, I'll pass it on to you, Dr. Levin.
Thank you so much, and thank you all for giving me the chance. Danny, your presentation and introduction to me was far too nice and not necessary. What we're talking about today is something that I'm very passionate about. I'm going to share my screen, and we'll go through this together. It's important to realize, as I click this, and hopefully you can all see me now, it's important for us to realize that what we're talking about today is a diagnosis that is preventable. And the term get uncomfortable is beyond wonderful, because it's not until we get comfortable with the uncomfortable that we're able to really make that diagnosis. So often we hear things, and when Danny was giving the presentation of me, which is awkward, you hear all these terms about dialysis. And believe it or not, when you see a nephrologist, if you see a nephrologist, the last thing we really want to stress is kidney failure. We really want to talk about kidney health, kidney strength, and maintaining kidney function. To me, that is far better than the alternative. So it's by learning about these things that we can make progress. Now, I've honored to work with Armenia. I feel that as an entity, their major goal is that of patient care. And anytime that we have an individual and a company that have the same goals, there's great success. Keep in mind that, as you know, lupus is a serious chronic disease, and there are, unfortunately, many complications. And I'll make the suggestion or the argument that if we can find those issues early, those complications do not have to exist. We can prevent them. So lupus, or systemic lupus erythematosus, is an immune response that attacks the healthy cells in the body. The exact reason why people get it and why people don't get it is still undetermined, but it affects many different parts of our body, from our joints and our skin and our brain and our kidneys. And when the kidneys are affected, it's called lupus nephritis. As you're going to see as we go forward, that all of these things occur. And on top of that, we're going to have about 50% of the people who have lupus may progress to lupus nephritis, which we really want to avoid that happening for obvious reasons. The kidneys are fascinating. They're really just beyond remarkable, which is probably why we haven't figured out a way to reproduce their function yet. And when we have this proverbial attack by these antibodies on the kidney, it's causing inflammation. And if that inflammation goes unnoticed or unchecked, it can cause permanent renal damage, lead to kidney failure, kidney disease, and for certain individuals, they can progress to dialysis and or require a transplant. All of which, if we have the opportunity, is preventable. So you can see here that when they don't function properly, the waste doesn't remove from our bodies. We can't get rid of these toxins. And with that said, we may feel sluggish. We may have, rashes. We may itch. We may have swelling. And we're going to go through all this together. It's not as uncommon as we think it is. And when we look in the United States, there are approximately 100,000 people who have lupus nephritis in the United States. Not lupus, but lupus nephritis. About 1 in 3 are diagnosed with lupus nephritis at the time of their biopsy. And generally speaking, it's more common in women than men, but when men are affected, they can be significant. I think the purpose to understand is that really it affects everybody. And with that said, as those are affected, we are now developing these much more comfortable treatment strategies that give us success and less side effects, giving us great outcomes. Like any other disease that's autoimmune, there always are some racial and ethnic groups that have different cohort rates. So it's 4 times higher in African Americans and Asian Americans and those of Asian descent, and 2 times higher in Hispanic and Native American populations. So we're always keeping this in mind as we're diagnosing things and looking at people. Again, these are these uncomfortable facts. Why are they uncomfortable? Not because they're uncommon, but they're too common to make us comfortable. We really want to understand that these are concepts that can lead to outcomes that are less than ideal for us. But with the knowledge that 1 in 3 will experience kidney failure, and that these guidelines to get tested more often, and that unfortunately the risk of death is greater for people with lupus, we need to be that much more proactive, break down these discomfort barriers, and find a way to get everyone who has these diagnoses tested and evaluated to prevent progression. There are these complications related to lupus, and the key here is to catch it early. So patients may have higher blood pressures. Patients may have this chronic kidney disease, of which we consider there to be 5 stages, and they're just based upon scarring and declining kidney function. Patients may have risk of cardiovascular disease, which sometimes go hand in hand with kidney disease. And as kidney disease progresses, it can go to end-stage renal disease, which we want to avoid at all costs for obvious reasons. The signs and symptoms of lupus can be subtle. They can be inconsistent, and they can be hard to recognize. And I think, being honest, when we have a diagnosis that we're uncomfortable with, sometimes instead of looking for progress and making more diagnoses, we give ourselves excuses of why this is happening. And because of that, we're less likely to seek help. So the swelling that can occur in our ankles, our feet, or our legs, that can occur due to loss of protein in our urine. And when we see that, our urine looks foamy, sudsy, that not just large bubbles, but really cloudy bubbles, so that after we go to the bathroom, and again, there's no harm in discussing our urine. Let's get comfortable discussing that. And generally speaking, men are much more comfortable looking at their urine than women because there is a greater population that do void standing up. So when we void and we see these sudsy, bubbly urine that we know and look for, it's almost as if we can't see to the bottom of the bowl. There's so many bubbles there, we can't see through the urine, and it's not that crystal clear urine that we expect to see. So this is this condition called proteinuria, which is one of the hallmarks of lupus nephritis. Also, as the lupus affects the kidneys get damaged. And inside the kidneys, there are different parts and different anatomy. And one of those is responsible for the absorption or filtration of blood. So with damage, there can be some blood in our urine, often microscopic, which means that we can't see that it's there. But when someone does a dipstick analysis or a microscopic analysis, blood cells are there. When lab tests are done, we can see abnormalities in kidney function and electrolytes. We can see a decline in our GFR, which is our glomerular filtration rate, which gives us a guesstimation, I'll say, of what our percent function is. And the alternative way of looking at a decrease in our GFR is the inverse of that, is an elevation of our serum creatinine. And then as this goes on, more and more that we'll do a kidney biopsy to help make the product tolerate the gift. So when people come to the office, they say, I'm really nervous about this. I don't want there to be any issues. What tests can we do to help make sure that we're stable? And that is the urine analysis that detects problems in our kidneys. We can look for urine samples, look for excess protein, which is that proteinuria. We can do these blood tests that are very important to determine if there's any waste or breakdown. And if necessary, a kidney biopsy can be done as an outpatient, usually in a hospital setting where we can look at it and determine the stage of kidney disease. So urine analysis is the hallmark of what we do. It's one of the easiest tests available. And in doing so with that, what we're going to see here is the ability to have an evaluation of how much protein there is. Many will make the argument that if there's more than half a gram of protein in our urine, there can be the chance of irreversible damage. I'll make the argument, because I'm always an optimist, that when we find that protein there, if there's more than an ideal, there are many things that we can do to bring that back to normal. And in doing so, bringing that down, we're going to get less inflammation and much more stability. We think it's really important that this is a co-managed situation, and we're dealing with both your family team, rheumatologist, and you. The patient is the captain of the ship. And we have to do a great job of making sure everyone's aware of what's going on. Choosing to prioritize your kidney is uncomfortable. Why do we say that? Because it's almost one of those things that we don't want to know exists. We want to make the assumption that our kidneys are functioning properly. We want to make the assumption that, we're going to get through this without any issues. So it's easy to ignore problems because of fear. And when that's the case, and missing appointments, and during the pandemic, people were phoning in things, we really didn't have as great a control over these things as we'd like. Again, when someone is diagnosed with lupus nephropathy, putting their health first is so important, because doing so, we can get further and further and further control. And in doing so, we're going to have less damage before it becomes too late. It's often asked is, what is the goal? And great question. And the goal is really keeping the patient engaged, keeping you understanding, keeping great lines of communication open. And on top of that, making sure that we're getting these routine lab tests, these urine tests, and these active discussions. It's not a big deal to come to our office and I'll say, here's a cup, go into the bathroom, give us a cup of urine. We're going to follow how much protein's in there. And as time goes on, hopefully that'll continue to decrease, decline, and get better and better. So yes, as we see here, the concept that peeing a cup does suck. And I think we have to get over this negative connotation that it's just more than urine. Urine is a hallmark of life, and we want to see how healthy your urine is. But if we ignore this and ignore this concept, there's a greater chance of having progression of kidney dysfunction, with the knowledge that up to 30% of the people who have lupus nephritis may develop kidney failure. I feel very strongly that this concept, while it's true, that percent can go down now that we have more and more ways of diagnosing this and having these great, very descriptive discussions for the health of everybody involved. So please, if you're concerned about this, it's very easy to get this evaluated, and the outcomes are far better than they used to be. And we're really excited about the future, because we know we can't change our genetics or hereditary or autoimmune system, but there are great ways to prevent this from getting worse. And the first way, it starts with knowledge. Again, you're your own best advocate. There's this QR code that you can scan and find a treatment specialist in your area. And I really do feel strongly that the more knowledge that we get and the more knowledge that we share, the better the outcomes are. Thank you. I'm going to stop sharing my screen and look forward to having any interactions with everybody. And do welcome any questions that may come up.
Thank you, Dr. Levin, for your presentation. It was very informative.
I hope my computer didn't freeze at all.
Now we will open the Q&A portion of the event. We will begin with the questions that were asked during the presentation. Feel free to ask additional questions while we are talking. We will try to get through as many questions as we can live, and we'll email you answers to any questions that we are not able to get to today.
Thank you.
So here's a question. Do I need to change my diet at all to keep my kidneys healthy?
It's a great question. So I do believe strongly in all these conditions that we talk about, diet awareness is very important. And this is something that we often bring up because we don't want to focus always on more and more and more medications. We want to talk about what we can do in a holistic manner in conjunction with the medicines that are around. So I do think it's very important for anyone who has protein in their urine, from whatever cause that may be, is to have a low salt diet. Salt will exacerbate or increase the protein in our urine. And it's amazing how many patients we come across that really find themselves being on a low salt diet, but it's the hidden salts in food that they don't realize. And depending on ethnicity, whether it be Hispanic or Asian populations or Native American populations, there are so many different hidden salts. So as a nephrologist, it's really important for me to be aware of the different cultural interests and be able to talk to the individual patient about where those hidden salts may be. Generally speaking, we don't want to have excess protein, but the average person who's not overly obsessed with going to the gym and building muscle is eating a normal protein diet. We don't want to protein restrict, but we want to have a normal protein intake. These are things that we're often looking at. Once your doctor has labs on you and is creating a successful plan, they might say to watch out for things that are rich in phosphorus or rich in potassium, but that's a one-off situation, not a general discussion for everything. What I mean by that is that if your potassium is normal in your blood, you don't need to restrict it. If your phosphorus is normal in your blood, you don't need to restrict it. So these are common things that we discuss in conjunction with the patients. And I really believe strongly that this should be an individual case discussion. Not that I'm uncomfortable with this, but there should be a deliberate plan made for the deliberate individual leading to success.
Our next question is, does having protein mean I will develop kidney failure?
No, so I believe strongly that protein is a marker of a disease, lets me know how much activity is going on in the kidneys, and the more protein, the greater risk of progression. But that's my target. So when I see how much protein's there, I'm going to go out of my way with diet, as we discussed, medications, avoidance of certain medicines to have that proteinuria level go down. So it's a great thing that I can follow much closer than ever before, leading to success. If the protein goes unchecked and gets higher and higher and higher, the potential for damage does exist. But if we find it early enough, the answer is we hope to keep the kidney health quite stable.
We have a question in the chat. Shante is asking, if you're spilling too much protein, do you need to consume more protein?
Yeah, that's a phenomenal question. The answer is no. What we want to do is keep our protein input stable. Years and years ago, we did studies looking at both aspects of that. Is if we're spilling protein, do we eat more to incorporate less, or do we eat less? And the really thing is to eat the normal amount. If we aggressive more protein just to make up those losses, that'll actually put more stress on the kidney. It's our job as the team approach to figure out why we're spilling protein and go after it through, other means, inclusive of some very easy to tolerate medications that may also help our blood pressure and also our lupus diagnosis. But encouraging high protein intake will not be a benefit.
Another question is, how many times do we have to submit our urine for testing, and what is the number should we be concerned with protein, and is this covered by insurance?
So great questions. This is 100% covered by insurance. In fact, the urine evaluation happens to be one of the least expensive tests that exist in medicine today. And we'll start by doing dipstick tests in the office that we do, for all of our patients without charge whatsoever. I always tell my patients that whenever they come to see me, it's not uncommon for us to ask for a urine sample. You don't need to fast for a urine. You have the privacy of going into a bathroom. And it just really helps us get a good grasp of that. So patients who have lupus disease and lupus nephritis are seen by a nephrologist, in my opinion, every several months, every 3 months or so. There are two ways of looking at it. One, we can do a urine in the office, or if we happen to go to the lab before our visit, we can have the urine done in the lab. So usually every 3 months. Again, it's exquisitely easy to get the urine sample. Years and years ago, we would ask patients to do what's called a 24-hour urine, where we'd have them key into a large container for 24 hours and keep it in the refrigerator. Those days are long gone, thankfully. It's just that cup that we showed on our slideshow, and we just can get that done and processed very quickly. Great question.
Do I need a biopsy before treatment?
There's so many different aspects to the phenomenal question of lupus. And based upon what the biopsy shows, can give us a lot of insight. With that said, if I have a patient who says, listen, I know that because of my protein and what's going on, I have lupus nephritis, I really don't want a biopsy. I'll never end that relationship with the patient because of that. Yes, it'll provide me more information, but in this day and age, if an individual is hesitant to get biopsied or has some relative contraindications to that, we can actually make it a go and treat them without the biopsy. I do believe strongly the biopsy provides invaluable information, but I'd rather treat a patient and see some success than scare them off by the concept of a biopsy and then them get lost to follow up. But yes, biopsies are invaluable and very helpful.
Our next question is, how can the heart be affected by high blood pressure caused by lupus nephritis?
So when we have lupus nephritis and we're retaining fluid and retaining salt because of damage to the kidneys, that in itself can make our blood pressure go up. High blood pressure, from whatever the cause, puts stress on all of our organ systems. And as a nephrologist with our degrees in hypertension, we know that there's a lot of causes of what's called end organ or down the line disease associated with high blood pressure. And the greater we can control the pressure, which is thankfully there are a lot of options to do so, the greater the outcomes. So high blood pressure can affect the inside of the heart, the outside of the heart, the valves, the blood supply, and all of that damage can make the blood pressure even harder to control. So that's why seeing your physician, getting comfortable with the uncomfortable, makes it a great way to have your blood pressure checked. We do believe strongly that all of our patients who have high blood pressure should have a cuff at home that they put in their upper arm and feel comfortable checking their blood pressure at home with the knowledge that they can call us at any time with a concern and let us know how they're doing.
Our next question is, what is the protein number would you initiate a treatment?
I think it's a phenomenal question. It depends on the individual and what's going on. We really want to see as low as possible. So, when we talk about treatment for proteinuria and lupus nephritis, we're looking at the whole thing. How active is the lupus? What symptoms do they have? What's their blood pressure? If a biopsy was done, what does it show? We're looking to keep the protein low, so less than 500 milligrams per gram or less than 0.5 as the readings will show. If it's above that, I would say depending on how high above it is, we'll be able to give us a reflection of what treatment should be done. I strongly believe that we should individualize treatment to the person, the patient, the individual, not just the number, which means that I'm going to create a customized, detailed treatment plan that my patients are going to understand, that they're comfortable discussing, and that's going to be specific to their needs. I'm going to alter that for each patient. There's a lot of overlap of what we use and what medicines exist, but they all have the same goal, which is that proteinuria reduction. How we get there depends on what other issues that patient has.
I think that's all oh, we have another one. Okay, if I have SLE and progress to lupus nephritis, will you be treating it differently or separately?
Lupus nephritis is a progression of lupus. So, for example, if someone has SLE, but their SLE or lupus is under good control, but we're seeing this progressive proteinuria and then abnormalities on biopsy, there are other medicines we're going to use to help prevent this aspect of the diagnosis. And by changing medicines, we may minimize some things that were on before because we're having breakthrough of a diagnosis on something that we thought was controlled. So there are times that we do additive effects or adding medicine on, and there are times that we're going to substitute medicines in and out. Again, phenomenal question. I think the best thing to do is look at it. I believe this strongly that in anything that we do in our specialty, we should cater and tailor to the individual. But there are many times that we're going to add medications. One of my things that I hate is this, what I call this pancake effect, which means, medicine, 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 medicine. We don't want to stack medicines on it. It's okay to say, I've been on this medicine for a while. I'm seeing this diagnosis. I don't think this is working as best as possible. I'm going to stop this medicine and substitute something else out. So there can be fluctuations, and that's why we want to see you and have discussions with you about this.
I think that's all we have, right? For us.
Well,
Thank you.
thank you for having me, and I love these questions and I love this interaction, and I'm always available, and I feel very strong about this community, this team, and seeing the global success. So I'm glad I had a chance to talk, and thank you for giving me your time today. Thank you.
Thank you, Dr. Levin. We really appreciate your time and expertise.
Thanks so much.
We will now welcome our lupus patients who will be participating in the lupus patient panel. Today, we will hear from Shantae and Yvonne. We will begin with each patient's stories, and then I will be asking some questions. If you have questions that you would like to ask, feel free to type your question in the chat.